Okay, let's unpack this. Today in the deep dive, we're taking a deep plunge into a really crucial text for anyone in nursing, Varkarolis's Foundations of Psychiatric Mental Health Nursing, 8th edition. And specifically, we're pulling out the vital insights from the chapter on trauma, stressor-related, and dissociative disorders. Our mission today is basically to give you, our dedicated learner, a clear, structured handle on these complex psychiatric nursing concepts, everything from assessment to intervention, keeping it accessible, relevant for your studies and for your future clinical practice. Think of this as your shortcut to really grasping the what and the why behind caring for patients dealing with the profound effects of trauma.
Indeed.
Yeah.
We'll be distilling that core knowledge, yeah, and detailing how nurses actually apply these skills in real-world scenarios. We'll clarify diagnostic criteria, treatment strategies, all of it. This isn't just about memorizing facts, right? It's about understanding the nuances, the ethical considerations, and how every single concept connects back to your NCLEX priorities and your real-world responsibilities. We'll also try and describe those key charts and case examples you might see in the textbook, so you get the full picture, even without the visuals right in front of you.
Okay, great. So to start, it's really vital to understand that traumatic events aren't always these extraordinary things like war. They can be incredibly common interpersonal experiences, things like abuse, neglect, or even the sudden traumatic loss of someone close. Our understanding of trauma's long-term effects, both physiological and psychological, it's really expanded. And effective treatments do exist, but here's a crucial point. People who need these treatments often don't get the care they require.
That's so true, and that's exactly why integrating trauma-informed care into all healthcare settings is so vital, not just behavioral health, medical settings too. This approach, it can really reduce the damaging, kind of pervasive psychological and physical consequences we see so often.
Right, it shifts the perspective entirely.
Exactly. And, trauma can actually precede a lot of psychiatric disorders.
Eh.
According to the APA, the disorders under this trauma umbrella include PTSD, post-traumatic stress disorder, obviously. Then you have attachment disorders, acute stress disorder, and adjustment disorders. And because trauma impacts kids differently than adults, related ways, but often different, we'll talk about them separately. We'll start with children, then cover adults. And finally, we'll get into dissociative disorders, which are also closely tied to trauma, especially chronic or repeated trauma. That includes things like depersonalization and derealization disorder, dissociative amnesia, and dissociative identity disorder.
Okay, let's start with children then. When we talk about trauma-related disorders in kids, their vulnerability is it's particularly heartbreaking. Children are exposed to so many potential traumas, abuse, violence, accidents, disasters, even scary medical procedures, and they often lack those developed coping skills to really defend themselves adequately. The statistics are pretty sobering, like neglect is the most common form of child abuse in the U.S. And alarmingly, most child fatalities from abuse happen to kids under 3 years old. Witnessing violence is also a huge risk factor for, a whole host of mental health problems, depression, anxiety, and definitely PTSD.
Yeah, and the clinical picture of PTSD in children, it can look quite different from adults. Take preschool kids, for example. Their PTSD might show up as a reduction in play, or maybe repetitive play that keeps reenacting parts of the trauma. You might also see social withdrawal or these persistent negative emotions, fear, guilt, anger, sometimes self-blame. They might seem detached, lose interest in things they used to enjoy, irritability, aggression, sleep problems, trouble concentrating, hypervigilance, all common signs. So for you as a nurse, the key takeaway with children's PTSD, especially kids 6 and under, is recognizing that their symptoms might not look like an adult's. Instead of clear verbal memories, you might see play that reenacts the trauma. That's a big one. Their nightmares might be scary, but maybe not obviously connected to the event. Flashbacks could look like that trauma-specific reenactment during play, and things like intense emotional outbursts, pulling away socially, or just a lack of positive feelings that might be how they're expressing what an adult would call fear or guilt. These symptoms, they have to last more than a month, cause significant distress, and importantly, not be due to substance use or another medical issue. The DSM-5 also specifies if the child has dissociative symptoms, like feeling detached or delayed expression, if the full criteria pop up later, like 6 months or more after the event. Looking at the numbers, adolescent research points to a PTSD rate around 5%, and girls have a significantly higher rate than boys, and sadly, for children who witness horrific events, like a parent's murder or sexual assault, the chances of developing PTSD are almost 100%. It's devastating. Comorbidities are also really common, and they just increase a child's vulnerability. Kids dealing with toxic stress often meet criteria for multiple diagnoses. This can lead to this seemingly endless cycle of meds, punishments, inadequate responses. It can re-victimize and stigmatize them. You often see things like nightmares, trust issues, phobias, learning problems, depression, substance abuse, all alongside the PTSD.
Wow. So if trauma is this prevalent and has such a deep impact, what's actually going on underneath?
Yeah.
Biologically, in the brain, and those early relationships? What makes someone more vulnerable?
That's a really central question. Biologically, yeah, genetics play a role in how we react to stress. And prenatal exposure to maternal stress can actually influence how the baby responds to stress later on. What's even more profound, though, is that early adversity has been found to literally alter DNA in the brain through a process called methylation. Think of methylation like a dimmer switch for genes. It can turn them off or on. In this case, it can dim the brain's natural ability to regulate stress. And that leads to long-term challenges, difficulty with attention, more aggression, impulsivity. Thankfully, parental nurturing can sort of mediate this, buffer it. Neurobiologically, those first 5 years are just critical for brain development. It makes kids incredibly vulnerable. Trauma can actually disrupt the neural networks that process social emotional info and regulate body functions. When arousal gets really intense, the experience is less likely to be processed adaptively, stored correctly. The more helpless a person feels during the trauma, the more vulnerable they are to these pathophysiological changes. Stephen Porges' polyvagal theory gives us a fascinating lens here. It helps understand the autonomic nervous system's responses to threat. It goes beyond just fight or flight. Sometimes the body goes into a kind of playing dead response, that dorsal vagal state, that leads to profound withdrawal, almost like depression. And this can alternate with that sympathetic hyperarousal, the anxiety state. It helps explain why so many people with PTSD also struggle with depression. It's that swing. Recognizing these different physiological states is really key for tailoring support. Psychologically, attachment theory Bowlby's work highlights how crucial those early infant caretaker bonds are. Those early patterns get formed through interactions, embedded in memory, and they often persist right into adulthood. Environmentally, we have to consider neuroplasticity, the brain's ability to reorganize itself. It's intense in childhood. That, plus their dependency on others, increases their vulnerability to adverse childhood experiences, ACEs. Things like poverty, parental substance abuse, exposure to violence, they significantly raise the risk, especially for minority kids. But it's also crucial to remember resilience, that ability to adapt positively despite adversity. Factors like social support, positive emotions, self-efficacy, they boost resilience, which really points towards using a strength-based approach in nursing. It can be very promising.
Okay, that's a lot of really important background. But as a nurse, maybe on shift tonight, I'm thinking, how does this actually translate? What's the absolute first, most critical step in assessing a child with suspected trauma symptoms? Something beyond the usual checks.
Right. For a child or adolescent with a suspected trauma or stressor disorder, comprehensive assessment is key, partly because the development might be delayed. Nurses in all sorts of settings, schools, community health, even juvenile detention, need to assess for PTSD and, crucially, ensure the child's environment is safe. Data collection involves interviewing, screening tools, testing, observing them, interacting. And ideally, you're gathering info from multiple sources: parents, caregivers, the child themselves if possible, teachers. Sometimes a genogram can be useful. That's like a family tree drawing that shows relationships, helping understand family dynamics. When doing a mental status assessment for kids, nurses look at things like safety, general appearance, how they socialize, activity level, speech, coordination, affect, their intellectual function, thought processes, and really importantly, the characteristics of their play. For younger kids who maybe can't answer direct questions well, play activities are invaluable. Using games, drawings, puppets, it lets you observe and helps build trust. Key post-traumatic symptoms you're looking for include nightmares, flashbacks, any self-injurious behaviors, dramatic mood swings, and somatic symptoms, those physical complaints. A developmental assessment is also really important to see if they're hitting age-appropriate milestones. Early intervention for any delays is critical. Based on all that assessment data, 2 priority nursing diagnoses often come up: risk for impaired attachment, which is about vulnerability in that nurturing parent-child bond, and risk of delayed development, looking at potential delays in social, cognitive, language, or motor skills. So our outcomes would naturally focus on seeing an enduring, affectionate bond develop and seeing the child meet those age-appropriate milestones. Now, for implementation, the overall treatment plan for trauma usually follows a 3-stage protocol. Stage 1, safety and stabilization, that's foundational. Stage 2, reducing arousal, regulating emotion, and working through traumatic memories carefully. Stage 3, Developmental skills catch up, building healthy social connections. Nurses aim to help the child stay within what's called the window of tolerance. That's that balanced state between being hyperaroused, anxious, aggressive, and hyperaroused, withdrawn, numb. Our interventions are designed to kind of widen that window, help them stay regulated.
That window of tolerance concept is such a useful way to frame the goal. So how do nurses actually actively guide a child back into that window when they're struggling?
Well, improving relationships and connection is fundamental. The nurse-patient relationship itself provides a safe connection. Specific interventions include establishing trust and safety, using language that makes sense for their age when exploring feelings, and teaching relaxation techniques before you even start exploring the trauma. This gives the child a sense of control. Using art and play therapy is huge for helping kids express feelings they can't maybe verbalize. It's also vital to involve parents or caregivers, assuming they aren't the source of the trauma, of course. Nurses often coordinate with social work too, if needed. For instance, if a child mentions an imaginary friend that sounds like a coping mechanism, you can offer reassurance. You might say something gentle like, sometimes when really bad things happen, our brain tries to help us by forgetting. And sometimes it creates special parts of ourselves, like friends, to help us cope. Traumatized kids also need to learn strategies to regulate their emotions. Things like deep breathing, mindfulness exercises can help decrease that arousal. For advanced practice, therapies like cognitive behavioral therapy, CBT, and eye movement desensitization and reprocessing, EMDR, are first-line evidence-based treatments. EMDR basically helps patients process traumatic memories through a combination of focused attention and bilateral stimulation, like specific eye movements or sounds. Regarding meds psychopharmacology, it's important to note there are currently no FDA-approved medications specifically for childhood PTSD. However, SSRIs might be used off-label for certain symptoms or for co-occurring issues like ADHD or depression, ideally alongside therapy, not instead of it. And we know treatment is working when we see the child's safety is maintained, their anxiety is reduced, their emotions and behavior are more appropriate for their age, when they're achieving normal developmental milestones, and importantly, when they can seek out adults for comfort and help when they need it. Okay, now moving on briefly to attachment disorders. These stem from really inadequate caregiving environments, and they lead to two sort of extreme patterns in how children bond or fail to bond.
Right. One extreme is reactive attachment disorder. Here, kids show this consistent pattern of being inhibited, emotionally withdrawn. They rarely seek comfort, even when distressed, and don't really direct attachment behaviors toward caregivers. Then there's the seemingly opposite extreme, disinhibited social engagement disorder. These kids can seem remarkably friendly, almost overly confident. They show no normal fear of strangers, they're overly familiar, wander off, they rarely check back with caregivers. It's like they attach to everyone but have no deep, secure attachment to anyone.
Exactly. These disorders are actually quite rare, maybe around 1% of kids under 5. They often co-occur with other problems, depression, anxiety, learning difficulties. While some historical attachment therapies were controversial, most effective modern therapies focus on improving the interaction between the caregiver and the child, and those can be quite successful.
Okay, let's shift gears now to adults. PTSD in adults. It involves that persistent re-experiencing of a highly traumatic event. Things like military combat, natural disasters, violent crime, a life-threatening illness, where the person felt intense fear, helplessness, or horror. What's important to remember is that even indirect exposure can cause it, like learning a loved one experienced violence, or being a first responder dealing with horrific scenes repeatedly. And symptoms don't always start right away. A delayed onset months, even years later, isn't uncommon.
Yeah, and the flashbacks and hypervigilance in adult PTSD, they can be absolutely terrifying. When a traumatic memory comes up, the body reacts physically, heart pounding, stomach churning, muscles tense. The person often doesn't realize these feelings are tied to the past. They feel like they're happening now. It makes the past feel incredibly present and dangerous. Those brain changes we talked about can lead to these radical swings, moments of intense anxiety and overstimulation, then suddenly shutting down into depression or numbness. People often feel permanently damaged, maybe even hate themselves for feeling so needy or helpless. It's incredibly painful.
And it's widespread. Most people, somewhere between 55% and 90%, experience at least one trauma in their lives. But only about 8% actually develop PTSD, and women are more than twice as likely as men to develop it. This might be due to higher rates of sexual assault and perhaps a greater likelihood of having pre-existing anxiety or depression.
Comorbidities are definitely very common in adults with PTSD. Major depressive disorder, other anxiety disorders, sleep problems are frequent. Substance use is also really common, often as an attempt to self-medicate those overwhelming feelings. Patients might come in with chronic pain or just vague physical complaints. You often see sadness, anhedonia, that inability to feel pleasure, aggression, anger, guilt. And they frequently struggle in relationships, personal, social, work. Trust is almost always a major issue.
So how do we, as nurses, assess and support adults who are struggling with these really profound impacts?
For assessment, screening tools are often the first step. Things like the Primary Care PTSD Screen, PCPTSD, or the PTSD Checklist, PCL5. The textbook also mentions tools like the Severity of Post-Traumatic Stress Scale. This is basically a self-report where patients rate how long they've been bothered by specific symptoms in the past week, things like having flashbacks or feeling very emotionally upset when something reminded you. Beyond screening, nurses need to gather a detailed history, onset, frequency, severity of symptoms, how much it impairs their daily life. And crucially, we absolutely must assess for suicidal or violent ideation. That's not negotiable. We also need to look at their support system, sleep patterns, current life stressors. The priority nursing diagnosis here is often post-trauma syndrome, that sustained maladaptive response to a traumatic, overwhelming event. Our outcomes would then focus on helping the patient manage anxiety, maybe through relaxation or better sleep, boosting their self-esteem, and improving their coping skills. In terms of implementation, that three-stage treatment model we mentioned for kids, it applies to adults too. A primary consideration, and maybe the most important thing, is establishing a strong therapeutic relationship, one built on non-judgmental acceptance and empathy. This relationship helps the nurse assist the person in managing their arousal level, keeping them within that window of tolerance in a safe, predictable environment.
Right. And practically speaking, that means teaching those anxiety management techniques, deep breathing, imagery, mindfulness, things they can actually use. Connecting patients to support groups or helping them reconnect with family and friends if that's appropriate is also vital. Patients often carry immense guilt and feel responsible for the trauma. As nurses, just by listening and reflecting, we can gently help them challenge that belief, suggesting maybe they weren't responsible for what happened. Just sharing the experience, talking about it in a safe space, is a huge step towards healing and integration.
Absolutely. And psychoeducation is key here too. It's important to reassure patients that their reactions are common responses to trauma, not a personal failing. We educate them on how trauma can show up, maybe through relationship problems or substance use. We teach coping strategies, self-care skills, and advise avoiding things like caffeine and alcohol that can worsen anxiety. Pharmacologically, the best evidence for PTSD symptoms supports SSRIs, like sertraline and paroxetine, which are FDA approved. Other meds might be used off-label, like prazosin, which can help with nightmares. And it's worth mentioning the ongoing FDA trials for MDMA, or ecstasy, as a potential adjunct to therapy for PTSD. Early results show some promising symptom reduction and lasting improvements.
Let's make this really concrete with that brief case scenario from the text. Mr. Blake. He's 46, an Iraq war vet. His wife brings him to the ED after finding him writing a suicide note. He's subdued, smells of alcohol, says he's worthless, doesn't deserve to live. His wife reports he's been struggling since losing his squad, can't sleep, irritable, withdrawn, drinking daily.
Right. So Mrs. Dawson, the RN on the psych unit, assesses him. She observes he's hypervigilant, startles easily. He scores high on a PTSD scale. Given his clear verbalized intent and a plan, her priority diagnosis is immediately a risk for suicide. The immediate outcomes. He needs to remain safe while hospitalized, talk to staff about self-destructive thoughts, and hopefully express a desire to live. Now, Mrs. Dawson's interventions are very specific and purposeful. One-to-one surveillance for safety, administering meds with mouth checks to prevent hoarding. When discussing suicide, she's direct but non-judgmental, showing acceptance, building trust. She interacts with him regularly, not leaving him isolated, to convey caring and encourage communication and the evaluation. It showed these interventions worked. Mr. Blake started contracting for safety, began talking about his self-harm thoughts, and eventually admitted his anger and grief. He stated he didn't want to hurt his family. It really shows how applying the nursing process step by step can lead to tangible positive changes. And of course, longer-term advanced therapies like trauma-focused psychotherapy and EMDR would be crucial for someone like Mr. Blake.
That case really highlights the long shadow severe trauma can cast. But like you said, not all stress responses become chronic PTSD. Sometimes the symptoms are more immediate, maybe shorter-lived, or tied to less severe stressors. Let's touch on those variations now, starting with acute stress disorder.
Okay, acute stress disorder, or ASD. This involves symptoms developing right after a traumatic event, and they last from 3 days up to 1 month. If those symptoms hang around longer than a month, then the diagnosis typically shifts to PTSD. Think about the vignette of John, the 22-year-old college student who was sexually assaulted. He describes feeling detached, not remembering things during the assault, feeling agitated, irritable, having trouble concentrating. A week later, he still feels detached and has nightmares. Those symptoms fit the criteria for acute stress disorder pretty clearly. Nursing interventions for ASD focus on building that therapeutic relationship, ensuring safety, providing education about the typical responses to trauma. It's important to note that something called critical incident stress debriefing, or CISD, which used to be common, has not actually been found effective. It might even increase PTSD rates in some cases. But CBT and specialized EMDR protocols are showing promise for ASD too.
Okay, and then there's adjustment disorder. This sounds like a milder, maybe less specific response, triggered by stressful events that aren't necessarily life-threatening dramas, like maybe retirement, getting a difficult diagnosis, or a painful breakup.
Exactly. That's a good way to put it. The hallmarks are cognitive, emotional, or behavioral symptoms that cause distress and negatively impact functioning, but in response to an identifiable stressor that isn't necessarily traumatic in the PTSD sense. These symptoms can look like depression, anxiety, or social withdrawal, or a mix. There's even a complicated grief subtype specifically for prolonged distress after losing a loved one. Treatment isn't uniform, but often involves antidepressants to manage the mood or anxiety symptoms.
Okay, we've covered a lot about how trauma impacts us. But what happens when that impact is so profound, it actually fragments our sense of self, our connection to reality? That takes us into the really fascinating, sometimes confusing realm of dissociative disorders.
Right. Dissociative disorders generally occur after significant adverse experiences or traumas. They involve this unconscious defense mechanism where the individual emotionally separates from overwhelming anxiety. But this separation results in disturbances in memory, consciousness, self-identity, perception, kind of like the integrated functions of self fall apart. Now, a really crucial point. Patients with dissociative disorders generally have intact reality testing. This means their flashbacks, for example, are triggered by current events but relate clearly to past trauma. They aren't delusions or hallucinations like in psychosis. Pathological dissociation isn't like that common feeling of being on autopilot. It's involuntary, and it results in fragmented memories and experiences. Symptoms can be positive, like flashbacks, or negative, like memory gaps or feeling numb. The three main types we'll touch on are derealization disorder, dissociative amnesia, and dissociative identity disorder.
Let's start with depersonalization, derealization disorder. So depersonalization, that's that really unsettling feeling of being detached from yourself, right? Like you're watching your own body or thoughts from the outside, almost like being in a dream.
Precisely. And derealization is similar, but the focus is on the outside world feeling unreal. It's a recurring feeling that your surroundings are unreal, distant, foggy, distorted, like living in a dreamlike world or behind a veil. The textbook example of Elizabeth, the 42-year-old executive, illustrates this well. After her son's legal troubles trigger extreme stress, she feels her body looks wavy and out of focus, like she's floating in a fog, and her life feels like a dream she's just watching. That captures both aspects.
Okay, next up, dissociative amnesia. This is about an inability to recall important personal information, usually something traumatic or stressful. And it can be localized, meaning you forget everything from a specific period, or selective, where you only forget some parts of an event or time.
Exactly. And a specific subtype of dissociative amnesia is dissociative fugue. This is characterized by sudden, unexpected travel away from home, coupled with an inability to recall one's identity or past. Sometimes the person might even assume a new identity during the fugue state, like the example of the young woman found wandering in Florida, no idea who she was. It turned out her boyfriend's suicide preceded the fugue.
And finally, the one people often think of, perhaps due to media portrayals, dissociative identity disorder, or DAD. The essential feature here, as I understand it, is the presence of two or more distinct alternate personality states, often called alters. These alters recurrently take control of the person's behavior, and each has its own way of perceiving, relating, thinking, its own patterns. And this is strongly linked to severe, often horrific childhood trauma, right?
That's absolutely right. Indeed, you typically have what's called a host personality, the primary identity, which often isn't aware of the other alters. The host might be confused by lost time, finding items they don't remember buying, being called a different name. The alter states are often fixated on traumatic memories. They can have unique behaviors, memories, different names, sometimes even different perceived ages, genders, races, or religions. Even voice patterns or handedness can differ. Switching between these personalities usually happens during times of stress,
The prevalence rates for dissociative disorders generally range from 2% to 10% over a lifetime, which is actually pretty significant. DD specifically is estimated around 1.5%, and comorbidity is extremely high. These disorders often travel with major depression, anxiety, PTSD, personality disorders, substance use. It's complex.
Very complex. The primary risk factors are almost always severe childhood abuse, physical, sexual, or emotional, or other overwhelming traumatic experiences. Dissociation, sometimes called mind flight, is fundamentally a defense mechanism. It reduces the overwhelming feelings and protects the person, in a way, from the full conscious horror of the trauma. Neurobiologically, early, prolonged detachment from caregivers seems to impact the limbic system development. And during severe threats, the body releases endogenous opioids, which might alter communication between brain structures, basically inhibiting the normal integration of traumatic memories. Psychologically, dissociation is seen as this primitive ego defense. There's a theory called the theory of structural dissociation of the personality. It suggests complex trauma leads to different parts of the personality, one part focused on daily life, the apparently normal part, and another holding the trauma memories and emotions, the emotional part that fail to integrate. Environmentally, it's a response to overwhelming experiences, combat, incest, torture, prolonged neglect, and it's important to touch on cultural aspects too. Some culture-bound syndromes, like attack de nervios, seen in some Latino cultures, involve dissociative symptoms like feeling out of control, trembling, or trance-like states. But interestingly, research suggests that while the descriptions might vary culturally, the underlying experience of dissociation, like feeling detached or having memory gaps, seems quite similar across different cultures. It points to a potentially universal human response to extreme stress.
That really raises a crucial question. How do nurses even begin to approach care for individuals whose sense of self, whose reality might feel so fragmented?
Well, it's true that patients with dissociative disorders often initially seek help for depression, anxiety, or maybe suicidal thoughts, because living this way is incredibly distressing. Key assessment areas then include a really thorough history of life events, looking especially for early trauma or neglect. And a detailed memory assessment is critical, checking for clarity, consistency, any reported gaps, disorientation, periods of lost time, or blackouts. If dead is suspected, nurses might gently ask specific questions like, have you ever found clothes in your closet you don't remember buying? Or, do friends ever tell you about things you did that you don't recall? Assessing suicide risk is absolutely paramount and needs to be done directly. Asking about ideation, intent, plans. Also, assessing for self-mutilating compulsions or other physical harm is crucial because sometimes due to the dissociation, patients might not even be fully aware of injuries they've sustained. Now, for nurses, it's natural to feel maybe uncomfortable, confused, or even skeptical when working with these patients. It can be challenging. So self-awareness is key. Managing your own reactions, maintaining strict professional boundaries. Think about the textbook's critical thinking exercise about Jean, the 48-year-old with JID, who threatens suicide to get rid of all the others, her alters. Staff might feel uneasy, maybe doubt her intent. But the nurse's immediate response has to be safety first. One-to-one monitoring, removing harmful objects, while still approaching her directly and non-judgmentally about her feelings. Our outcomes for someone like Jean would initially focus on her remaining safe, being able to talk about her self-destructive thoughts, and eventually expressing a desire to live. Interventions would involve creating that safe, predictable environment, using strategies to build trust, and encouraging her to communicate about all her feelings related to all parts of herself. The overall long-term goal for dissociative disorders is developing an integrated and complete perception of self. Healing is seen as this process of integration and linking neural networks that got disconnected by trauma. Nurses provide that steady emotional presence, ensure safety, and encourage the highest possible level of function. Basic interventions include things like establishing simple, predictable routines, confirming identity and orientation frequently but gently, encouraging self-care activities, supporting the patient during the exploration of feelings but being careful not to flood them with too much traumatic material at once. Allowing the patient to progress at their own pace and empathetic listening are absolutely crucial. Psychoeducation is also vital. Normalizing their experiences, framing dissociation as an adaptive response to overwhelming events can be incredibly validating. A core skill to teach is grounding techniques. These help disrupt dissociation and keep the patient connected to the present moment. They can be really simple physical or sensory things. Stomping your feet on the floor, taking a shower and focusing on the water temperature, holding an ice cube, deep breathing, touching the fabric of a chair. Journaling can also be helpful for tracking experiences and feelings. And again, pharmacologically, it's important to stress there are no specific medications for dissociative disorders themselves. But meds like antidepressants, anxiolytics, or sometimes antipsychotics might be used carefully to target co-occurring symptoms like hyperarousal, intrusive thoughts, depression, or anxiety. Advanced practice nurses might use specialized therapies like CBT adapted for dissociation, modified EMDR, psychodynamic therapy, or hypnotherapy. Somatic therapy is also gaining traction. It recognizes that trauma often gets stored physically in the body. These therapies combine talk with body-centered interventions like sensor-motor psychotherapy, aiming to disarm that pathological dissociation and promote better body awareness and mindfulness. Ultimately, evaluating treatment effectiveness means looking for patient safety, reduced anxiety, return to better functioning, the integration of fragmented memories over time, development of new coping strategies, and the ability to handle stress adaptively without resorting to dissociation.
As we wrap up this deep dive, it's incredibly clear that the landscape of trauma, stress-related, and dissociative disorders is complex. But nurses play just an absolutely vital role in guiding patients towards healing and integration.
Indeed. It really runs the gamut, doesn't it? From understanding those intricate neurobiological shifts caused by trauma, all the way to implementing very specific, targeted nursing interventions. Every step in the nursing process for these patients really emphasizes that holistic, patient-centered care. Your ability as a nurse to connect with these patients, to establish trust, and to support their often long journey from fragmentation towards integration, it's truly transformative work.
So thinking about all this, what does it mean for you as you continue your journey in nursing? Maybe consider how recognizing the deep physiological impact of trauma right down to the brain's networks and the body's sensations, how that fundamentally shifts our whole approach to care. How might truly trauma-informed care, if implemented widely, transform not just individual patient outcomes, but maybe even the entire healthcare system? Something to think about.